So, good evening to all, and good morning to our friends from Houston. I welcome all of you on behalf of Heart Failure Foundation and my other co-directors, Dr. Bhagirat and Dr. Nagmalesh, to this webinar series on cardiomyopathy. So we're going to have spread over 3 weekends on Saturdays, different topics covering each aspect of cardiomyopathy. Today, our focus is on infiltrative cardiomyopathy. So we're going to have two lectures and followed by half an hour discussion. The moderator for this section is Vimal Raj. He is a lead consultant cardiothoracic radiologist at Narayana Hrudayalaya. After his training in Royal Brompton Hospital, London and Papworth Hospital, London, he worked as a consultant in Glenfield, Leicester, and he has about 80 publications to his credit, and he has authored numerous book chapters. He holds patent in postmortem CT coronary angiogram catheter design, is an avid educator, runs a fellowship program in cardiothoracic imaging at Narayana Hrudayalaya. He is also a convener for ACE Radiology Masterclass, an online class to train cardiothoracic surgeons, physicians, and radiologists in cardiothoracic imaging. I welcome Vimal. Vimal, please take over and conduct the proceedings.
Thank you very much, Karthik. Good evening, everybody, and welcome to the Heart Failure Foundation course on cardiac imaging, heart failure, and the upkeep of what is happening around the world. So on today's evening, I have got the privilege of introducing three panelists who will be helping us in going through the deliberations. First, I would like to invite Dr. K.R. Balakrishnan, who is the chairman of the Cardiac Sciences Director of Lung Transplant and Mechanical Circulatory Support from MGM Healthcare, Chennai. Dr. Balakrishnan has the accolade of doing many of the first procedures in India and has done lots of transplants work in India. So welcome, sir. The next chairperson is Dr. Mona Bhatia, a very good friend and a esteemed cardiac imager radiologist who heads the department of Fortis Escorts in Delhi. Mona is a beautiful teacher who has very great concepts, and I'm really glad that Mona is here on this panel. Welcome, Mona. The next person to complete the triad is Dr. Talha. Dr. Talha is a consultant cardiologist working at Fortis Hospitals, Mumbai, who's done his training in Pittsburgh in US and has got a lot of awards in America as part of his training. So welcome to all of you. This brings me on directly without much ado to introduce the first speaker for today, Dr. Arvind Bhimaraj. A lot of you probably already know him. He is the Assistant Professor of Medicine from the Weill Cornell Medical College, also a co-director for Heart Failure Disease Management in Methodist Houston, and also the Medical Director for Heart Transplant and LVAD program in the DeBakey and Vascular Center. So Dr. Arvind, welcome to this evening's program. We are really glad to have you here, and we look forward to you giving us a talk on the spectrum of infiltrative cardiomyopathies with special focus on sarcoidosis and amyloidosis. Over to you, Dr. Arvind.
Thank you very much, Dr. Vimal, and thank you to the Heart Failure Foundation and the organizers and the panelists for inviting me. I have had the privilege of being associated with the Heart Failure Foundation, and over a period of years, I've really cherished my experiences with my visits to the conferences, and I've also made really good friends with many thought leaders in India, and I consider that a privilege. So thank you all for giving me this opportunity. I think my screen's being shared, so I'm going to make sure. Okay. So my task today is to talk about infiltrative cardiomyopathies with a special focus on cardiac sarcoidosis and amyloid. I will for sure not talk much about imaging because I don't want to embarrass myself in front of some of the world experts here on the panel. So it'll be followed by my colleague and partner, Dr. Dipan Shah, who will talk about the imaging aspects of it. But These two disease entities are probably the most common representation of infiltrative cardiomyopathies, and have also come up in the context of both technological advancements and our understanding, along with therapeutic options. So it's very imperative for us to know the specific clinical scenarios in cardiac sarcoidosis and amyloidosis. So the infiltrative disorders come under restrictive cardiomyopathy. And as I said, amyloidosis, sarcoid are probably the most common. We will not talk about the rarer entities of Gaucher, Hurler, fatty infiltration. And the storage diseases are not technically infiltrative disorders, so we will also not focus on them today. So we'll lead in through a case, and as we walk through the case, I will probably talk a little bit about certain aspects of care learn through the case. So this was a 44-year-old woman with really no past history who presented to an ER, not at our institution, but a local ER, with episodes of syncope, 2 episodes in the first week. After the first episode, she went to her primary care who did an EKG and it was normal. So she was lingering around and essentially passed out second time. So she sought attention to the ER. She then also states that for 6 months she's had some tiredness, weakness, shortness of breath, no other significant symptoms. And she did have a non-invasive stress test and an echo before she came to the ER, and reportedly she was told everything looked okay. In the emergency room, her heart rate is 43, regular, mild distress, and this was the EKG that showed up. And it's obvious, all of us can recognize that she's got some high-grade conduction block. And it's relevant to be cognizant that this is a young woman with no other health history, and she shouldn't be having these conduction issues, which is where you get triggered about suspicion for some of the infiltrative disorders. Nothing significant in any of the lab work, really, maybe a little bit of albumin that's low. AST/ALT is slightly high, not clear whether it's a primary problem or she's perfusing low. EF is normal, not much of a significant echo, but if you look at the echo, there's some regional wall motion abnormality, maybe inferior thinning of the myocardium, but no other myocardial issues. So what do the guidelines say? If you go through HRS consensus, if you walk through this guideline, if you have a high-grade block in someone who's less than 60 years of age, you should be suspecting infiltrative disease, more so sarcoid because of its predilection to the conduction system. So the workup should include a high-resolution CT and possibly advanced cardiac imaging if you have access to it. CMR and FDG PET are the two that top up. And if you don't have any of these positive, it's probably low likelihood because there are good imaging techniques which will pick up something. But if they're positive, we do have to go down the pathway of chasing the diagnosis, preferably with a biopsy, either a non-cardiac accessible tissue or even a cardiac biopsy. And if it's negative in the cardiac biopsy, we'll talk a little bit, you still have to have a high index of suspicion to try and come up with a diagnosis. So what we ended up doing for this lady is she got transferred to our hospital for further workup and essentially for a cardiac MRI. But she came in a quite an unstable state with a complete heart block, so they had to rush her to the EP lab, and they decided we did an EP study. She did have an inducible monomorphic VT needing defibrillation in the lab, for which she ends up getting dual chamber ICD placed. At this stage, she had some investigations at an outside institution, and everything was reported normal. Later on, I was able to get the records and review. Her lungs were quite unremarkable, no lymphadenopathy. And then she got out of the hospital with a follow-up plan because she felt great and she didn't want to stay in the hospital. And so if you look at the discussions for ICD in sarcoidosis, If you have a spontaneous VT or an arrest, or your EF is low, it's quite obvious ICD is recommended. But even if you don't have it, you're doing a permanent pacemaker implantation, have an unexplained syncope, or have inducible VT on EP study, I think these are indications where ICD should be considered. Because the mistake that can happen is if you just put in a pacemaker in this individual without checking and then sending her home, VT could be the reason for sudden death in this individual. So let's take a pause and talk about what sarcoid is. And I think all of you are aware of what the disease is, but it's still a lot of enigma in the context of the predisposition and causative agent. But there's a genetic predisposition for HLA2 antigens, that is DRB1 and DQB1. There's some familial risk. There's a possibility of viral and bacterial infectious agents perpetuating it, and then some also inorganic agents. All these essentially become antigenic stimulants for T cells and antigen-presenting cells, and not getting too much into immunology, it essentially goes through a series 4 T cell activation, forming granuloma and fibrosis. And it's a perpetuating cycle between collagen synthesis and degradation, and hence forming the pathognomic feature of a granuloma. I think many of you probably are more experts than what we here in the UST, with tuberculosis being one of the infectious diseases that can cause a similar granuloma, and it's very important to rule out the infectious agents causing this particular entity before calling it sarcoid. So this is a characteristic feature of a non-necrotizing granuloma for sarcoidosis. Clinical presentation, the reason why this is relevant to acknowledge is a lot of studies scored about 5% incidence in the heart, and majority focuses in the pulmonary. But I think a part of this data is erroneous in the fact that there's prevalence in cardiac sarcoidosis is probably much higher than what we know. Up to 25% of some of the postmortem studies have found sarcoidosis and involvement in the heart. And I always wonder how many of these non-ischemic cardiomyopathies, which we kind of have a random label, might be missed as a sarcoidosis. So always keep in mind, while it's a systemic disease, all other areas can get involved. For our topic of discussion, you do need a high index of suspicion to make sure it's in the heart. Briefly, there are various clinical criteria. The Japanese ministry diagnostic criteria, which was revised in 2006, is one of them. But essentially, it factors around the same clinical index of suspicion, which if you have a cardiac biopsy, which is straightforward, but a clinical diagnosis is factored into by major criteria and minor criteria, which includes what we talked about a little earlier: advanced AV block, basal thinning of the ventricular septum, positive cardiac gallium uptake. This is not widely used, especially with the FDG PET availability, and the EF, which is low. If you have 2 of the 4 major criteria, then you should suspect, especially with the extra cardiac disease that already has sarcoid. Minor criteria are abnormal EKG, abnormal echo with regional wall abnormality, perfusion defects on scintigraphy without coronary disease. And then when you do a biopsy, if you find some monocyte infiltration, you might have missed the organized granuloma. Heart Rhythm Society also has a criteria, not going too much into the details. It's similar to what we talked about, but they do have added cardiac FDG PET, which is more current, and then the LGE on cardiac MRI, which is consistent with cardiac sarcoidosis, and other causes of cardiac manifestations, of course, have been reasonably excluded, because you still have to go through your coronary disease risk factors. But the outcomes, when you talk about this is a classic paper by Felker in 2000, when you talk about infiltrative diseases, sarcoidosis is somewhere in between for their outcomes. And it's important to recognize that 50% of these patients who ended up being sarcoid were labeled as idiopathic cardiomyopathy for a while before the diagnosis was made. And when you look at therapeutic data and outcomes, it's an indolent disease, which means that they're dragging it out for a while. And this study showed that their overall prognosis, this is in days. So this is a Japanese study, and most of the functional class for these patients, NYHA class, was a predictor of bad outcomes, and so was LV and diastolic dimension, which was statistically significant. But therapeutic implications do show that if you catch it early and treat, we could make a difference. And you see the survival curve separate out in the study with people who were on steroids versus not. And within patients who had steroids, of course, if the EF is low, they do worse. And this prolonged indolent disease is important to recognize because this is classically different from all the other myocarditis that we see. And this is why we end up seeing as end-stage organ failure specialists, we end up catching these patients referred for transplant and VAD after a while. And there was a lot of lost opportunity for us to have picked up sarcoidosis. And this is true because this data that you have here that I'm showing are two studies. The top one, when they look back in all the explanted hearts after transplant, you notice that of the 5 patients who ended up having sarcoid diagnosis, only one of them actually had a diagnosis before transplant. The rest all were probably labeled as non-ischemic cardiomyopathy. And this happens even in my center. I would say one case in 2 years, we find that the explanted heart ends up showing sarcoid granulomas, and the patient was never diagnosed with it. So did the Cedars data show, which is listed below, that of 19 hearts that they found sarcoid granules, only 4 had a diagnosis before transplant. Sudden death also has some contribution to it, even though in this study I think this was out in the UK, majority of the pathology showed lymphocytic myocarditis, but granulomatous myocarditis, which technically is sarcoid, could be the cause for some of the sudden death episodes. So biopsy indications, and I'm a big proponent of biopsy because you shouldn't shy away from biopsy as long as it's done in a center which has expertise. Globally, across even in the US, if the centers do not have enough expertise, then you want to make sure you get them to those individuals. But the guidelines have a 2-way recommendation for unexplained restrictive cardiomyopathy, but you should suspect that there is restrictive cardiomyopathy. As I mentioned, the complication rate for biopsies is not that lethal or terrible if the indication is necessary. Even if you go into LV endomyocardial biopsy in this European data, I think the minor complication rate is like 0.64. So it's something which can be considered if you need to. So we ended up doing a standard endomyocardial biopsy in this individual. This was probably about 6-7 years ago. And essentially unremarkable, no granuloma, no myocarditis, nothing showed up. Even electron microscopy was performed and nothing really showed up in this. And that's not unusual. It's a patchy disease. And in this autopsy study that you see those white scars, there's no way you can go to it if you're on the RV septal biopsy, because normally when we do a biopsy, we go through the IJ, essentially go in and you're taking a septal piece of the RV. So she continues along at this stage and no one's kind of pushing the suspicion. Her CT scan of the chest was normal. There's no lymph nodes. There's no other lung area. And within a month or so, she starts having VT episodes, which are real VTs. And I'm glad we did the EP study with successful ATPs. There's a surgical wound breakdown. So there was a debate between doing empiric steroids, but the surgical wound breakdown was quite bad that they did not choose. Bottom line, we started discussing doing LV biopsies. And at this stage, as I said, 7 years ago at our center, we were not doing LV biopsies routinely. So she continued to get worse, and with more ICD shots despite amio. And then at that stage, essentially, we said we should probably get her in, get a VT ablation, but at this time, we planned for an EP-guided myocardial biopsy. So what is EP-guided biopsy? And when we were doing this in our center at that time, these were a few studies that were published. We had not started EP biopsy, so this was kind of our first case for it. But the EP mapping has been shown to guide to the area of myocarditis or any inflammation for that case. And these were a couple case series that were published, which increased the yield for myocarditis, both in the US and in Europe. So but most of these studies that I'm showing were RV biopsies with the EP guidance. There was only one case at the time which showed LV biopsy, which was a transaortic biopsy. So we essentially did what led to the first-in-man case of a robotic-guided biopsy for sarcoidosis, which was published in Circulation. But what you see here is a robotic sheath using a Hansen robot, which is used for VT ablation. But what I wanted to point out is this is really a curve which goes through the venous system, transeptal puncture, and all the way up to the LVOT. And what we did was we took a biopsy of the LVOT, and that's exactly where the sarcoid showed up. That was the only piece that showed up sarcoid. So we were lucky we were able to continue to treat. And really after that, with steroid treatment and continued management, currently she's stable, really off of her medication. So the treatment for sarcoid, typically early on, especially for cardiac, is high dose steroids. I normally start at 60 milligrams daily and slowly taper it down with at least 6 months to 1 year. And in between, we're beginning to start steroid-sparing agent, but a lot of the recommendation is to at least treat for a year. The steroid-sparing agents can be methotrexate, azathioprine, TNF-alpha inhibitors. But we're beginning to use more of CellCept because we're more comfortable with CellCept in transplantation, and CellCept seems to be working okay based on the data and evidence. So that's about sarcoid. And quickly moving into amyloid, I think I'm probably getting close to my time. Amyloidosis is a very different entity, because what we have to remember is infiltration can be with anything. And in sarcoid, the infiltration is granulomas. And amyloid, it's infiltration from extracellular deposition of insoluble fibrils and proteins. There are a variety of proteins, probably close to 100 or 125, have been potentially shown to cause amyloid deposition in various tissues. But remember that it's a pathological diagnosis. It's the definition of amyloid is finding these beta-pleated protein deposition, and any protein any certain class of proteins, when they deposit in a beta-pleated fashion shown here, they end up being positive for, in H&E, they look like kind of pink globules around the cells. And you have to do Congo red stain that shows the classic pathognomonic findings shown here. And if you put that through tissue through polarized light, it becomes apple green birefringence. The important entities that cause amyloid are AL amyloid, which is light chain amyloid, caused by monoclonal light chain. So it's a B cell problem, right? The antibodies are made, light chain is a part of immunoglobulins, and then immunoglobulins are made by B cells, so it's a plasma cell proliferation problem. And I call it, personally, I call it like a cousin for multiple myeloma, because amyloid is more protein production and multiple myeloma, it's more cell proliferation. And it's important to know that because there's overlap. Sometimes people get labeled as multiple myeloma. From hematology standpoint, the treatment's no different. But from cardiac transplant consideration, it's important to distinguish that. Very often cardiac involvement, these are really sick patients. I have grown to fear them based on our experience. If somebody has AL amyloid with bad cardiac involvement, today if I see them in the office, I do not send them home. I admit them and make a decision. Either they get a transplant or they go on hospice if the cardiac involvement is bad. TTR amyloid is been there for a long time, but our recognition has increased relatively recently. And TTR is transthyretin. Transthyretin is a transporter of mostly retinoic acid, but also of thyroid hormone. At about 10% of the transport of thyroid hormone happens with this. but it's a protein that's made in the liver, and everybody have it, except that when it gets mutated, it doesn't form the specific tetramer that it needs to, and becomes what I call a sticky protein, so it goes and sticks to various tissues. When you have a mutation that's been described and runs in families, or you find any mutation that's been described, we end up calling it familial. And if you don't find a mutation, we call it wild type. Senile amyloidosis is a description which we used in the past, but we're not talking about it as much, because essentially if an old individual gets a diagnosis of amyloid, if they have a mutation, we still call it familial. If they don't, we call it wild type. But both these are similar entities, and it's a spectrum of different involvement of organs. Some have more predisposition to the nerves versus the heart. The other two I'm not going to cover much, but secondary amyloid is because of inflammatory diseases and hemodialysis associated with beta-2 microglobulin. Not much is known about these entities. So quickly, certain pearls are myocardial hypertrophy in these patients is not equal to myocyte hypertrophy. The heart looks thick, but it's not because of the myocytes, but it's because of all these material in between the cells, and that's what causes the low voltage EKG. The heart looks thick on echo, but the EKG doesn't support that, and that's the reason for this. Conduction system gets affected. This is very dangerous if people just go into standstill because of this. Coronaries can get affected. Heart valves are thickened, but not much of a clinical implications because our pericardium can get affected. We haven't seen any clinical implications due to that. So if you have any of these low red flags, low voltage on EKG, thickened echo, thickened RV, cannot tolerate these medications, and then low blood pressure and history of carpal tunnel syndrome or of any neuropathy, you have to suspect amyloid. And the two amyloids that you should look for is AL and TTR. And AL has more of a nephrotic syndrome, the systemic symptoms, versus TTR has more of a specified areas, for example, carpal tunnel and some spinal stenosis. If you're African American in the US, it's easy to get labeled as hypertension. And new diagnosis of HCM should be a rarer entity in elderly individuals. So you should have a high index of suspicion for this. EKG, all of you know, the only caveat I want to say is that it's relatively low EKG compared to echo is how I look at it, because they might not meet the textbook criteria of low voltage on the EKG as such. Pseudo-infarct pattern and conduction abnormalities. Echo, just a reflection, it's the thick LV that you see in these images. And of course, if you look at the EKG at the bottom, it's not to scale, but sometimes I look at this with a suspicion that the voltage is low in these individuals. So clinical workup, if you suspect, first thing to do is to order labs. Look at the serum light chain, order serum protein electrophoresis. A word of caution not to jump to order the technetium pyrophosphate without these labs, because the ability for technetium pyrophosphate to pick up amyloidosis, because it's very specific to TTR, is by the fact that you've ruled out AL already. And this is a blood disorder, this is a liver problem. So that's a very two distinct things. And without knowing that, if you refer a cardiac amyloid patient to the hematologist when it's TTR, they look at us like we don't know what we're talking about. The gene testing that's available commercially through the companies right now, essentially, if it's cardiac, there's a set of genes. What is fascinating is in this disease entity, there are about 100 gene mutations that have been described, and majority are actually probably all of them are single amino acid mutations. And based on where the mutation is, the protein sticks to different organs. It's a very fascinating concept. I don't think anybody has understood or researched that. But it's very important to recognize that you want to risk prognosticate these patients because they might not look that sick. So use biomarkers. These are simple studies to do. So for AL amyloidosis, this is a study from Mayo that showed that if you have a troponin T greater than this value, NT-proBNP, and light chain difference, using these three criteria, they divided into stage 1 to 4, and you get 1 point to each. Look at how dismal the outcome here is. If you're stage 4 and you're sitting in my office, because most of the times, unfortunately, these patients have a lag of 2 to 4 years before anybody suspects amyloid. And 1 year, this is survival. 1 year survival is poor, 30%. So they just drop dead like anything, unless you're stage 1 where you have some time to figure these things out. TTR amyloid is a little different. Its prognosis is not as bad as AL for whatever worth, and I think a part of it is to do that it's a systemic disease. There's also some toxicity to the fibrils of light chains that we see. But in this particular, same thing from Mayo Clinic, Grogan published this, using 2 of these criteria, troponin T and proBNP. If you look at it, that if you have both those, this is a flip of the previous one, this is death. And even if you have stage 3 at 1 year, your mortality is about 30%, not survival. So TTRs are a little better. And another European study also did the same staging, but using NT-proBNP and eGFR. But the concept is that make sure you look at this and see which ones your patients belong to. And going quickly into treatments, right now we have good treatment options for the TTR amyloid. AL amyloidosis has had a plethora of improvement in their ability to treat with chemotherapy, but I'm not going to go into the details for it. The final treatment is bone marrow transplant for the AL amyloid, but for the TTR amyloidosis, until recently, only options we had was to do a liver transplant at the end stage. A lot of studies on doxycycline end stage, but nothing really panned out. So the new medication, which is the new kid on the block, which probably has helped make us familiar about this condition, is tafamidis. And tafamidis was studied in this ATTR-ACT study. And just to show that it takes a while for us to see the mortality benefit, almost an end of like 18 months is where the graphs separate, because this is an indolent disease. What this medication does is essentially mimics the thyroid kind of a receptor and binds to the sticky protein, so that the sticky protein is not available to go and stick to other organs. So the rate of progression decreases and hence the outcome improves. The other medication I want to mention is Onpattro, which is a completely different way it acts. This is an RNA silencer. So it goes and silences the RNA synthesis of this protein. Because the protein, the problem in this protein is it's made and then it's misfolded. So if you go to the source and not make it, the hope is that people will do better. And Onpattro has been studied more so in hereditary amyloid patients and with polyneuropathy, and it's an infusion that's done every 3 months, every 3 weeks, and then you show that it's shown that there's a significant improvement in neuropathy. So if somebody has familial hereditary and have neuropathy, sometimes we can add this to tafamidis that we've been using historically. To wrap up, when these patients become end stage, transplant is probably the best option. LVADs are a disaster because RVAD use is very high. Few centers have published successful outcomes. We have not had great success with VADs, and we've stayed away from them because we have an amyloid transplant program. Essentially, a total artificial heart can also be a nightmare because of the friability of the tissues. So these are tough entities for mechanical circulatory support. But you can create a multidisciplinary organ transplant program, which takes a lot of effort. And this is our recent publication to show that about 47 of them evaluated over a period of few years. Essentially, 18 resulted in an AL amyloid heart transplant, which were 14 were heart and 2 were heart kidney. And the TTR amyloidosis were mostly heart liver, so it did 8 of them. So this looks like small numbers, but amyloid transplants are not an easy entity, not many centers do it. But the important fact is if you do it right, these patients, AL amyloid compared to non-amyloid, their survival is about the same. So catching them early, if you can avoid transplant, treating them, but if you cannot, getting them to transplant sooner than later is relevant. And if you compare various centers in the US, Mayo has had the most extensive experience. They've done about 23 transplants. We've done about 16. But if you look at 1-year survival, we're one of the higher survival with a good volume. And these are tough cohorts of patients, and selection is extremely relevant for them. So in summary, and I apologize, I'm a few minutes over, but infiltrative cardiomyopathies need a high index of suspicion. Sarcoidosis is more prevalent than previously thought, and I've begun to suspect anybody who has a non-ischemic cardiomyopathy, unless there's a reason, I think we should think about inflammation in the heart in general, and then cardiac sarcoid becomes one of those. The MRI, PET, and targeted biopsies are needed as an effort for sarcoid if it's heart isolated. If you have other areas, then that's perfect. Cardiac amyloid is lethal, especially AL, and it's appropriate that we should be afraid of them. A lot of, I didn't talk about pacemaker need and ICD. It's a controversial area for amyloidosis, especially ICDs. Pacers are probably straightforward if you need them. And there are various medication options for TTR amyloid, very expensive at this stage though, and transplantation is possible, but needs a focused multidisciplinary team. With that, this is my email address, and I'm happy to take any questions, or I guess I'll defer back to the chairperson so we can see if you want to do questions later. Thank you.
Thanks a lot, Arvind. Thank you very much. That was really detailed and very useful. Thank you. I would suggest all the attendees, if you have any questions, then on the right-hand side bottom of your screen, there is a chat window. You can post your questions there and we can take them up one by one. Would like to go straight into the next talk, but I'll just ask our chairpersons if you had any comments or if you would like to ask any directed questions to Dr. Arvind before we introduce Dr. Dipan. Just for the chairpersons, Dr. Balakrishnan has a question. Sir, please go ahead.
I have a comment. I really enjoyed this talk. We have a limited experience of transplanting in diseases. I think. Can you hear me? Can you hear me?
We can hear you now, sir. Yeah.
Okay. We've had, I think, 2 patients with amyloid who were transplanted. And one of them, as you mentioned, eventually after, it turned out to be multiple myeloma. I don't know why the diagnosis was missed. And then he sent him to a hematologist for a possible, whatever, for the treatment. But he didn't do too well. He died after 1.5, I think, or 2 years. The other one is doing well. We had 2 patients with sarcoid. Both were presented as restrictive cardiomyopathy with severe pulmonary hypertension. And at one point in time, we were considering whether we should do a heart and lung because she had 2 episodes of cardiac arrest. And her PVR was very high, but we could find an oversized donor, and she's doing well. The sarcoid has done well. And one other patient, of course, that's not part of this discussion, was a patient with glycogen storage disease, a Pompe's disease. And again, a severe biventricular disease. And these storage diseases are a mess. As you said, it's no fault of the patient. They are born with some congenital defect which nobody understands. There are enzyme treatments which are so expensive that, experimental. A lot of them actually come from the pediatric community because a lot of them present in children as well. And in this patient, we put in a VAD. Fortunately, the right ventricle recovered, even though she had a cardiac arrest, was put on ECMO. And eventually, the right ventricle recovered. So she was a long-term survivor on VADs. So my question is, have you seen a sarcoid with both cardiac and pulmonary involvement?
Yes, no, and I think, first of all, I would acknowledge that these disease entities are really tough, and unless people take an extra interest and get involved, it gets missed a lot. And the example I want to give is we started our amyloid transplant program about 12 years ago, at which time, when I got out of my fellowship, I still thought amyloid was a rare disease until I came here and started my job, and it's everywhere. So if you don't look for it, you don't find it. And to answer your question for sarcoid, yes, so we've done probably 2 heart lungs in couple patients One more lung involvement with interstitial involvement, and the other one had actually worse heart. But once we diuresed, put an impella, and got the wedge down, the lungs did not improve. And when we did a biopsy, she did have a quite extensive impairment of PFTs. So we've done a couple of them, but more so, most of the sarcoids we've done are pure heart transplants.
So when you say you do a biopsy, you do a heart or lung biopsy, or you do both?
So in the patient I'm talking about, had a known diagnosis of sarcoid with a tissue biopsy elsewhere, had a diagnosis of non-ischemic cardiomyopathy, came in with what sounded like cardiac arrest and heart failure, and her wedge was 30. Lungs looked bad, but she never was on oxygen before. So by the time we optimized her heart, it took about 2-3 weeks, and the lungs didn't improve, both radiologically, CT scan wise. So we ended up doing a lung biopsy to prove that it is a sarcoid involvement, to then get her a heart and a lung. Because if it was some other diagnosis and we could do a heart alone, that was the hope, to get away with the heart alone.
Okay.
I'd like to make a comment too. I'd like to make a comment. Yeah, so I also find that sarcoidosis is definitely undercalled in India, and given that we have tuberculosis as a very close mimicker, so invariably we get these granulomas in the myocardium, and then the question is it tuberculosis or sarcoidosis, and the treatment is so different. So we do end up doing a lot of mediastinal lymph node biopsies, because some of them may or may not have the lung lesions. But yeah, it's definitely undercalled, and there's a lot of sarcoid around in India. So it makes it really more important to get the biopsies, and it could be extra cardiac or intracardiac, whichever way.
Okay, Dr. Talha, your comment, and then we'll go on to Dr. Dipan.
Thank you, Dr. Arvind. That was a wonderful talk. It's both a comment and a question. In India, we are stuck with a dilemma, at least as far as I'm concerned, and according to my local whatever research I could do, was that even on cardiac biopsy specimens, we are not able to differentiate between AL and TTR. We can just do Congo reds and the polar microscopy and tell whether this is amyloid or not. But the whole point of being able to differentiate on biopsy is not, we are not able to do that because we don't have mass spectrometry. When I inquired, I was told that this would be a send out test to somewhere in US or Europe, and it would cost a whopping 1.9 to 2 lakhs to do that, to run the test. And so eventually I was left with, why would I even do the test? So we rely more on imaging. And another point related to this is that we still don't have tafamidis available in India. So, so the only thing that I tend to look at is just make sure it's not AL. And if it's not, because that's a separate treatment. And if it's not AL, it's TTR, then, supportive therapy it is for the patient. What would your approach be, Dr. Arvind, when you're sort of practicing in such an environment?
So I think you bring up very valid points, which I didn't go into details. And to us right now, distinguishing AL and TTR is extremely important. But I would say 10 years ago, when we didn't have the TTR treatment, my philosophy would be, if you're not AL, even if it is TTR, I don't know what I'm going to do. Except that when we had a heart-liver transplant program, it became imperative to make sure that they had TTR. But there's no way around, because amyloid will look like amyloid unless you do the chromatography as you suggested. Even for us, we have not invested in our own institution, even though we are a big center. We just send it out to Mayo and then Florida, 2 places that they do, and you have to type it out. But in your setting, to your point, if you have no availability for tafamidis and there's no discussion for a heart-liver transplant and they're older, it becomes irrelevant to chase it down. You want to make sure you just rule out the blood part of it. And that's also important. And going back to Dr. Balakrishnan's point, that these patients for AL need a bone marrow transplant. And after heart transplant, it has to be combined with the bone marrow. We do it after a year. Mayo does it after 6 months. And that's the only way you can assure the good outcomes for the long term.
Thanks a lot, Arvind. Just for the attendees, there are two different ways you can ask questions to the panelists and the faculty. At the bottom of the screen, you have a Q&A. I have seen some of the questions, and we will discuss them after Dr. Dipan's talk. The other way is to just put your comments or questions on the chat box, and we will take them. So this brings us on to welcoming Dr. Dipan Shah. Dr. Dipan Shah is the founding director of Cardiovascular MR Laboratory in Houston Methodist, the DeBakey Heart and Vascular Center. He is one of the imagers who's been training a lot and conducts multiple courses. And I hope he will be throwing a lot of light on many of the questions which have been asked here about how do we differentiate and what is the role of imaging in infiltrative cardiomyopathy. Off to you, Dr. Dipan.
Okay, thank you very much. It's a real pleasure to be here today. And what I'm going to do here, let me just get share my screen with you all, is maybe broaden it up a little bit and just talk about what is the role for cardiac imaging and specifically cardiac MRI in the evaluation of cardiomyopathies. So I think, you know, the first question is, what are the tools that CMR can offer when you're evaluating patients with cardiomyopathy? And here, I think before I get to some of the more sophisticated tools, I think simple things like LV function assessment and LV volumes is actually crucial. And MRI is an ideal tool to be able to quantify volumes and ejection fraction without the need for any geometric assumptions. But I think what probably most people think about when they think about cardiac MRI is this late gadolinium enhancement CMR tool, which really allows us to be able to directly image myocardial fibrosis. And in the setting of ischemic cardiomyopathy and ischemic heart disease, obviously, we've been using it for many years because it helps us to identify the presence of a myocardial infarction. And not only the presence, but actually to characterize the extent and the type, whether it's a subendocardial or transmural. And, you know, we go back now almost 20 years, the original publication by Raymond Kim that showed that in the setting of ischemic cardiomyopathy, the amount of hyperenhancement, delayed enhancement in any given segment is inversely related to the likelihood of improvement after revascularization, such that for those segments that have nearly transmural hyperenhancement, the likelihood of improvement is very low. I think where it can be useful beyond ischemic heart disease is we know that one, the pathophysiology of ischemic heart disease is such that you get this wavefront phenomenon of injury, so that when the artery is acutely occluded, initially you get injury in the subendocardium, and then over the next 2 to 6 hours, it progresses to the mid-myocardium, and then eventually, after 6 or more hours, it becomes almost transmural and extends all the way through. But again, the key is that it starts in the subendocardium and works its way outward. So when we do our delayed enhancement MRI and we find patterns of hyperenhancement that are not consistent with this wavefront phenomenon, such as this mid-wall pattern, this epicardial pattern of enhancement, or this very diffuse pattern that doesn't fit with any non-coronary perfusion territory, that's a clue to us that there could be a non-ischemic cause of this myocardial fibrosis. And then more recently now, I would say really in the last 10 years or so, we've also had T1 mapping techniques, which allow us to visualize not just replacement fibrosis, but actually to infer the presence of expanded extracellular space, which is consistent with the setting of interstitial fibrosis. And so really it's coupling these two techniques together that we're going to use in trying to characterize cardiomyopathies more closely. And so, and again, if I look at it from a more broad standpoint, you know, I'll come back and focus on the infiltrative and inflammatory cardiomyopathies in a bit, but I want to just, you know, more broadly talk about the role of CMR in really this full spectrum of different cardiomyopathies, whether we talk about genetic, some of the dilated, as well as the inflammatory and the infiltrative or restrictive. Let's quickly go through some of the genetic cardiomyopathies where CMR can provide some information. Obviously, in this case, just by looking at the cine images alone, we can tell there's a problem here in the very apex. There's hypertrophy or increased wall thickness in the apical segments, and this is a clue to an etiology of apical hypertrophic cardiomyopathy. When we apply again our contrast MRI, oftentimes in these patients, we'll see not only fibrosis or hyperenhancement in the apical segments, but oftentimes almost a dense infarct in the apical cap in these patients with apical hypertrophic cardiomyopathy. And then in the more garden variety hypertrophic cardiomyopathy, where you see more of a basal septal hypertrophy, you also see these patterns of hyperenhancement, which again wouldn't be what you would expect with coronary disease. Specifically, there's kind of this mid-wall fibrosis that occurs in the septum at the RV insertion site, where the RV wall comes in and attaches to the LV wall. And so the presence of this can help with identifying the presence of a hypertrophic cardiomyopathy, but also the extent of this fibrosis can help with prognostication. And this is one of several studies that have come out in the literature recently, showing in fact that increasing burden of fibrosis in hypertrophic cardiomyopathy is associated with adverse prognosis, both from the standpoint of sudden cardiac death, but also from the standpoint of end-stage hypertrophic cardiomyopathy, as we see here as a larger and larger percentage of the LV mass that shows fibrosis, a higher likelihood of subsequent events over follow-up period. So I think in the setting of hypertrophic cardiomyopathy, I think CMR is able to identify the ventricular morphology as well as the function that we see in hypertrophic cardiomyopathy. But more importantly, I think it's able to identify the fibrosis and scar, and that this scar burden is independently associated with cardiac as well as all-cause mortality in these patients. Now, what about another genetic-based condition? This is arrhythmogenic RV cardiomyopathy, ARVC. And here again, we've got a series of CMR criteria which help you to come up with a major or a minor criteria for ARVC. And again, notice all of these criteria are really based on, first thing you need is to have some abnormality of motion. So you need to have regional RV akinesis, dyskinesis, or desynchronous contraction. And then on top of that, you need to have either dilatation of the RV or dysfunction of the RV. And then the extent of dilatation or dysfunction determines whether it's a major or a minor criteria for ARVC. Moving on, here's another condition, LV non-compaction. And in this case, we can see just off of the cine images alone that there's hypertrabeculation all along these apical segments with kind of a preponderance for the lateral segments. And in this patient, if we were to measure their volumes, the LV is dilated with an end diastolic volume of 190 milliliters, and the ejection fraction is reduced with an EF of 29%. When we go through and actually quantify the ratio of the non-compacted to the compacted myocardium in this particular patient, we get a ratio of close to 3. And there's CMR data now going back to almost 15 years, suggesting that a ratio of more than 2.3 to 1, now this is a diastolic ratio that we use for CMR, is pretty good at separating those patients who have LV non-compaction from those who have hypertrabeculation from other conditions. It's important to keep in mind that that's not the only criteria that we can utilize. There's another criteria, this is called the Jacquier criteria, which came out a little bit later, which looks at the total volume or mass of non-compacted myocardium as a ratio of the total amount of myocardium. And in this series, they found that a threshold of more than 20% of total non-compacted myocardial mass is associated with LV non-compaction. And if we look at the two criteria, the Jacquier criteria tends to be a little bit more specific, whereas the Peterson criteria that I talked to earlier of the ratio of 2.3 to 1 tends to be one that's a little bit more sensitive for LV non-compaction. Other findings that also go along with LV non-compaction, as you can see, There can oftentimes be trapping of blood in these deep recesses. And as a result, when we do our thrombus imaging, we can actually find the evidence of thrombus in some of these patients with LV non-compaction. But I think it's important to recognize there's really a spectrum, and no single criteria is going to be perfect for identifying LV non-compaction. Rather, you have to look at everything in the proper context. And there's some that have even speculated that LV non-compaction may not be a distinct entity in and of itself, but rather maybe simply a phenotype that could be due to a variety of different conditions. And so I think there's still a lot more work that needs to be done for us to get a better understanding of LV non-compaction. So let's move on to the dilated cardiomyopathies. And here's one, the classic example that we see of somebody who has Takotsubo's cardiomyopathy. The Mayo Clinic criteria are shown here for diagnosis of Takotsubo's. What do we see on CMR? Well, in this patient, you can see very nicely, there's a large area of Walmolsh abnormality that we see in the apical and mid-wall segments, leading to almost a ballooning pattern. This was a very nice study that's been out now for several years, looking at a series of patients with Takotsubo's in a multi-center fashion. And what they found was that there were really kind of three distinct patterns of abnormalities in these Takotsubo's. Most patients, 82% in this series, had this apical ballooning pattern that we typically think about. But interestingly, about 17% had more of a mid-wall ballooning pattern where you can see the basal segments and apical segments seem to be spared, but it's predominantly the mid-wall segments that are affected. And then a small percentage actually had this, what they coined a basal or inverted ballooning pattern, where the basal segments are abnormal, but the mid and apical segments are contracting normally. And then about 1 in 3 patients had RV involvement as well. And they termed these patients as having biventricular ballooning patterns. So again, I think, there's with Takotsubo's as well, although most patients present with the apical ballooning, there can be a spectrum of presentation as far as Walmolsh abnormalities go. One of the things, though, that the data seem to be showing is that there's not much in the way of late gadolinium enhancement indicating permanent myocardial injury in these patients with Takotsubo's. And as a result, most of these patients tend to have reverse remodeling and recovery of LV function over time. Let me show you another case. This is a 44-year-old gentleman who comes in with chest pain, has a history of tobacco abuse and a positive family history for premature CAD. He comes in on a Friday evening. His initial EKG is nonspecific, STT abnormalities, no diagnostic ST segment elevation. But over the weekend, while you're treating him with heparin and antiplatelet agents, he has a peak CK of 1,050 with a high MB of 105 and a troponin of 30. Monday morning, you take him to the cath lab as a presumed non-STEMI. His coronaries turn out to be, I'm not sure how well this projects on the screen here, but looks like a normal coronary angiography. So the question now, Monday after you do the cath, is we've got a case here, what we call MINOCA, myocardial infarction with non-obstructive coronary disease. And what's the underlying cause of this presentation? Well, this patient was referred then for a CMR. And what you can see when we do the delayed enhancement CMR, especially very nicely on the long axis views, is that you've got these multiple patchy foci of hyperenhancement that we see really predominantly in the lateral wall. The septal segments seem to be spared, but having some effect on the apical anterior segments as well. Obviously, in this context, this kind of multifocal pattern of injury would really be most consistent with myocarditis. There's several studies now in the literature validating the CMR findings of hyperenhancement in patients who come in with suspected myocarditis with actual abnormalities that you would see at the time of histopathology. And this is just one example series where they did biopsies within the left ventricle at the site of where the hyperenhancement was present. And they found, again, this pattern of enhancement, which doesn't fit with coronary disease, where it's an epicardial pattern. And in the vast majority of these cases, they found the presence of virus, either parvovirus or herpes type 6. and only in about 10% of the patients, the biopsy was negative. So the key here is doing a biopsy, not just in the RV septal side, but actually biopsying the area where you see the late gadolinium enhancement on CMR to improve your diagnostic yield. And then more recently, there's data showing not only a diagnostic utility, but also a prognostic utility in patients that come in with clinically suspected myocarditis. If their delayed enhancement MRI shows no hyperenhancement, these patients have a very good prognosis. But if they have any evidence of hyperenhancement, their prognosis is impaired from the standpoint of all-cause death, as well as cardiac death, and also sudden cardiac death. And then here's a series of patients with idiopathic dilated cardiomyopathy. And in this group, although most of these patients tend to have no hyperenhancement at all, some of them will have a pattern of kind of a mid-wall pattern of late gadolinium enhancement. And this mid-wall pattern is associated with worse outcome from the standpoint of all-cause mortality, as well as CV mortality or need for transplantation. And then I think most strikingly, it seems to be most closely associated with incidence of sudden cardiac death or aborted sudden cardiac death. So this may represent the substrate for arrhythmias that's present in patients with non-ischemic cardiomyopathy. And then this is now just showing a meta-analysis of multiple different series, which have also shown similar findings with the strongest relationship of LV hyperenhancement by CMR associated with sudden death risk in patients with non-ischemic dilated cardiomyopathy. So let me move now on to the inflammatory and restrictive cardiomyopathies. And we'll start off with a case. This is a 44-year-old woman who has really no past medical history. She came into the emergency department having had 2 episodes of syncope within the last week. On careful history, she does note that over the last 6 months or so, she's been experiencing increasing tiredness and weakness, as well as some exertional dyspnea, but she denies any chest pain, PND, orthopnea, or palpitations. Physical exam on admission is normal, but her vitals do show bradycardia, and her 12-lead electrocardiogram does in fact show that there appears to be complete heart block in this patient. So this is a patient that presented to one of our outlying community hospitals. The electrophysiologist was consulted to say it looks like this person has symptomatic advanced heart block and needs a pacemaker. And the electrophysiologist that was very astute said, well, it's unusual in somebody in this age group, in the age of 40, to need a pacemaker, and transfer the patient in to get a cardiac MRI scan and then subsequently a pacemaker to identify, is there some structural abnormality of the myocardium? And here's what the CMR on this patient shows. So you can see, if we just look at the cine images, I think there's several findings. One, obviously wall motion is normal in the sense that ejection fraction is preserved, but there's an area of regional increased wall thickness here in the basal septum. You can see that both in the short and the long axis view. There's also an area of increased wall thickness here in the apical lateral wall, as we see on the 4-chamber view. And there's also, interestingly, an area of increased wall thickness in the RV basal wall as well, as we see over here in the 4-chamber or on the short axis view. And couple this with the delayed enhancement MRI findings, where we see several areas of hyperenhancement. One, we see that area of increased wall thickness in the septum shows hyperenhancement. We see an area of hyperenhancement also in the apical lateral wall, as well as hyperenhancement in that increased wall thickness area in the basal RV free wall as well. In addition to that, T2 weighted imaging, and for those of you that are not very experienced with CMR, T2 weighted imaging is a technique that we utilize to try to identify the presence of increased water content, which is suggestive of acute inflammation, which basically helps us to say that, is this hyperenhancement that we're seeing due to chronic fibrosis, or is this due to acute myocardial inflammation and injury? And we can see increased T2 signal in those same areas that we saw increased wall thickness, suggesting in fact that this is all an acute process. And then we couple this with a survey through the chest, which allows us to look at the parahilar region as well as at the paratracheal region, where you can see multiple areas of lymphadenopathy. So obviously, when you put all of this together, the areas of increase, focal increased wall thickness, hyperenhancement in those areas, as well as this diffuse lymphadenopathy, these findings are all consistent with cardiac sarcoidosis. And I think this was the same case that Arvind may have shown you guys earlier. But this patient actually then went on to get biopsy. And again, this was a EP guided biopsy done within the left ventricle to try to improve the diagnostic yield. And it did show evidence of granulomatous infiltration present, consistent with sarcoidosis. This is one of the early studies with CMR showing, in fact, the varying patterns of myocardial damage that you see with sarcoidosis, where it can really be subendocardial, transmural, mid-myocardial, epicardial, affecting the septum or the lateral wall, and also affecting the RV. And so one of the things we always say in the CMR world is that sarcoid oftentimes is the great masquerader, because it can really give you any pattern of myocardial damage. In this series, what was noted was that the prevalence of myocardial damage by CMR was much greater than the diagnosis of cardiac involvement based on the Japanese Ministry of Health criteria, almost a twofold higher prevalence. And then multiple studies have looked at, from a prognostic yield standpoint, in patients who have known extracardiac or confirmed extracardiac sarcoidosis, the presence of late gadolinium enhancement on CMR within the heart is indicative of cardiac damage from sarcoid and of a worse prognosis in these patients. So, in sarcoid, what's the role of imaging? And I focus here predominantly on CMR, but I think I'll broaden it up a bit in a second. I think really there's two ways that we see patients with sarcoidosis in the CMR lab. One is patients who have known extracardiac sarcoid, where they're being referred to the CMR lab to identify the presence of cardiac involvement. But oftentimes, we'll see patients that get referred simply because of unexplained advanced heart block, especially if they're under the age of 60, if they have VT of unknown origin, or if they have new onset heart failure. And then in those settings, CMR actually is the first test that identifies or raises the suspicion of there being underlying sarcoidosis. And obviously, I think Arvind already touched on this, the fact that it can go undiagnosed. And this is just one of several series that have shown that at the time of transplant or LVAD, anywhere, different series have reported anywhere from 3 to 10% of patients actually had undiagnosed or unrecognized cardiac sarcoidosis. This was a nice meta-analysis that was recently published, which really identified the histopathologic findings in cardiac sarcoidosis. And this was looking now at all studies that showed actual autopsy images. And what they found is that in most cases, there was some evidence of LV subepicardial hyperenhancement or fibrosis on the histopathology. It was frequently multifocal, oftentimes involved the septum, and oftentimes had some involvement of the RV free wall. Now, obviously, these are patients that died with sarcoidosis. So keep in mind that there's likely a spectrum, and patients that we may see clinically, especially earlier in the disease course, may not have this advanced or this multiple locations. But the reality is that sarcoid can affect any single region of the heart. Let me wrap up now then with the infiltrative cardiomyopathies. And so if I show you the cine MRI in this patient, I think there's several things that we would notice. One is it looks like there's a pericardial fusion. That's the area of high signal that we see surrounding the heart. LV wall thickness is actually increased, and in this case, we measured about 1.6 centimeters. Interestingly, also, if you measure the RV wall thickness, that's also increased as well at about 0.8 centimeters.
Krishna Kumar, sorry to bother you, ma. Marina, classmate Prasad, orthopedic surgeon.
Okay, maybe if Dr.
వాళ్ళ
Golki,
ఫాదర్ 90 సంవత్సరాలు అంటే
Dr.
కోవిడ్
Golki,
పాజిటివ్
if
వచ్చి
you could mute
సాచురేషన్
yourself,
అరౌండ్
that would
94
be
అలా
greatly
ఉంది.
appreciated.
మా దగ్గర ఐసీలో ఒక
And
బెడ్ కూడా ఖాళీ లేదు.
as I'm going to continue
ఎవరో
on,
కొంచెం ఒకసారి
in addition to
వెరిఫై
that,
చేయగలరా
this
మన
person
దగ్గర?
would have
Yeah,
bilateral
better to
enlargement
keep
as
him in
well.
ICU.
If one of the moderators could mute Dr. Golki's mic, please. Thank you. The LV ejection fraction in this case is reduced, but not severely reduced. It's about a 47% ejection fraction. And the RV ejection fraction also is mildly reduced at 38%, increased LV mass. But again, I think all of these findings wouldn't give us a definite diagnosis. But I think if I show you the post-contrast findings, I think this becomes much more convincing and much more striking. What do we see? We see diffuse hyperenhancement of the LV as well as the RV. Notice on the 4-chamber and 3-chamber views, you also see significant atrial hyperenhancement as well. Look at the papillary muscles. You can see there's hyperenhancement of the papillary muscles also. And this is really a series of findings that we see with infiltrative cardiomyopathies and specifically with amyloid heart disease. There's numerous prognostic studies showing, in fact, that if you have patients with extracardiac amyloidosis, then simply doing a delayed enhancement MRI can help you to risk stratify these patients. If there's no hyperenhancement on the MRI in the heart, these patients tend to have a fairly good prognosis. But if there is hyperenhancement within the heart, that indicates cardiac involvement of amyloid, and the prognosis is much worse in these patients. And in fact, in this single center study, the presence or absence of late gadolinium enhancement was much better at stratifying than New York Heart Association class was. And then in a more recent multi-center study that we were involved with, we also identified in a multi-center fashion again that the absence of hyperenhancement in patients with known extracardiac amyloid is associated with a much better prognosis than the presence of any hyperenhancement within the myocardium. Now, some of the example cases I showed you are ones where there's kind of diffuse hyperenhancement within the myocardium, but recognize there really is a spectrum with cardiac amyloidosis, or a spectrum at which we may identify these patients. And here's a patient who has much less striking of a pattern of hyperenhancement. But again, several things you notice. One is there's increased wall thickness, and there's a much more diffuse, but a less intense, fine, patchy pattern of hyperenhancement. But this was also a patient who turned out to have ATTR amyloid. So I think from the imaging standpoint, you know, what you typically see, those classic example images where there's diffuse hyperenhancement everywhere, recognize that that may represent one end of the spectrum, and we need to keep your eyes open for patients that are earlier on within the disease course. Now, let me show you another case. Let me see if this will play for us. Here we go. 29-year-old African-American woman who comes in with pneumonia and chest pain. She has a small enzyme bump, a troponin I of 2.67. When we look at her cine MRI images, her overall LV function is mildly reduced only. It's not that bad at all. But you notice there's some areas of increased wall thickness. Sorry. As you can see here, all along the anterior wall at the base, extending down to the mid. And also you can see a little bit here on this long axis view in the anteroseptum as well. When we do the delayed enhancement MRI in this patient, you'll notice that there's kind of almost a 3-layer appearance. There's an area of normal myocardium, then there's an area of hyperenhancement, and then there's an area of basically hypo-enhancement or absence of gadolinium contrast uptake, and then another area of hyperenhancement at the blood cavity. And whenever you see this pattern, it raises your suspicion of a eosinophilic infiltration. And in fact, when we look at her labs, this person has elevated white blood cell count with a very high eosinophil preponderance. And this is really a classic CMR finding that you see in idiopathic hypereosinophilic syndrome. And this patient had eosinophilic myocarditis. After treatment with 3 months of high-dose steroids, as well as anticoagulant therapy, you'll notice that that increased wall thickness that was present on the initial scan now is gone. And you can see contractile function in this patient is back to almost normal as well. Okay, and then also when we did our post-contrast imaging after 3 months of therapy, we can see that that area of abnormality that we saw on the contrast MRI, that area of abnormality has also predominantly resolved as well. Let me wrap up here with the last few conditions. So here's patients who had Anderson-Fabry disease, and we know that this is one of those storage disorders. For whatever reason, they tend to have a preponderance of hyperenhancement that occurs in the basal infralateral wall. That's frequently seen. And I think, again, though, that although that pattern in and of itself can be nonspecific, and there's other conditions that can cause infralateral hyperenhancement, when we couple that with our ECV and our T1 mapping techniques, that's where we can further stratify, because there's certain conditions that lead to a lowering in the T1 values, the native T1 values, and those are predominantly anything where there's fatty infiltration, Fabry disease, and also iron leads to localized reduction in native T1 times, whereas most other pathology within the myocardium actually leads to an increase in native T1 times, as well as in our extracellular volume or ECV times or fractions. So to kind of wrap up, what are the characteristic late gadolinium enhancement findings that we see? This is just a nice schematic cartoon showing that obviously, if we talk about ischemic heart disease, we tend to see subendocardial or transmural patterns. If we talk about non-ischemic heart disease, you can frequently see a mid-wall pattern, but again, the location of it can be helpful. If it's septal in origin, oftentimes that's idiopathic dilated cardiomyopathy or myocarditis. If it's epicardial in origin, oftentimes that occurs with myocarditis, with sarcoid, with Chagas or Anderson-Fabry disease. If we see kind of septal involvement predominantly at the RV insertion sites, that's a pattern that typically occurs with hypertrophic cardiomyopathy or with RV pressure overload conditions. Epicardial patterns of hyperenhancement tend to occur with myocarditis or sarcoid, can also occur with Anderson-Fabry and Chagas. And then if you see kind of a global pattern of hyperenhancement, that's typically predominantly seen in amyloid. Sometimes we see this also in advanced systemic sclerosis as well. So I think what I tried to do today was really to kind of talk a little bit about how CMR, with its ability to directly visualize myocardial fibrosis by the late gadolinium enhancement technique, as well as the newer T1 mapping and ECV fraction techniques, can really be used, I think, to further characterize a patient with a non-ischemic cardiomyopathy. And so I think it really aids in not just diagnosis, but I think now we have significant data that shows that CMR can aid in prognosis assessment as well in these patients. So I thank you for your attention, and I'll turn it back over to our moderators.
Thanks a lot, Dr. Shah. To begin with, thank you very much. Those were really wonderful pictures, a real depiction of the entire focus of pathology. I would start off with the chairpersons if there is anything they would like to comment or question, and then I will go through some of the questions. The audience are free to ask questions. Dr. Talha, please go ahead.
Dr. Shah, again, wonderful pictures, very clearly representing the diagnosis, and you really talked us through the images really well. Again, going to come back to the same, my same issue of trying to differentiate between TTR and AL. So coming back to cardiac MRI, are there some finer signatures of TTR on cardiac MRI where you could differentiate between these entities? I do recollect, I think 1 or 2 papers from about 5 to 6 years ago where they use some kind of scoring, a quali score. I think that's what the name was, with pretty decent sensitivity and specificity. Do you report that along with when you're suspecting cardiac MRI?
No, I think that's a very good question, because obviously trying to differentiate between ATTR and AL is a key distinction. At this point, there's a few publications that in small series that have tried to say, okay, how can we differentiate between one and the other? I'll give you kind of some overall gestalt patterns. One is that the patients with ATTR frequently tend to have much more concentric increase in wall thickness and tend to have much more prominent increase in wall thickness than oftentimes the AL patients do. The ATTR patients are the ones that tend to have much more of a diffuse pattern of enhancement, whereas oftentimes the AL patients may have a lesser degree or more patchy or fine pattern. But I don't think, to be honest with you, I think that the data is convincing enough today that I would utilize any single or series of CMR parameters to definitively make a diagnosis of one form of amyloid or the other. I think more work and more data still needs to come out for that, to be able to do that. Because again, now that we have therapies, they're really very bifurcated as far as how you approach treatment of those patients.
I think some kind of scoring system where you can combine features of imaging like cardiac MRI, yes, and to go with that, perhaps things like clinical pointers like family history and presentation with different systemic involvement may be more useful than just focusing on imaging findings. I mean, it may improve, yep, your diagnostic yield.
Yep, I absolutely agree with you. Yep.
Dr. Mona, any comments? Sorry, Dr. Balakrishnan, please go ahead.
Yeah, I really enjoyed your talk. I have a slightly different question. As you know, not really anecdotally, but there are a category of patients with dilated cardiomyopathy who recover their ventricular function after implantation of an LVAD. I think Dr. Emma Burks as well as Frank Slaughter are into that based on a very regimented drug therapy. Do you have any experience on being able to perhaps predict which patients might have a reasonable chance of ventricular function recovery using CMR?
Yeah, no, I think that's a great question. There is some data, and we have some anecdotal experience that suggests one is that patients who have higher and higher fibrosis burden, those are patients with a more advanced dilated cardiomyopathy and are less likely to have recovery with medical therapy or with optimization of therapy. But that's actually an area Arvind and I are working on right now, is to say, okay, can we systematically look at predictors? And it's probably not just going to be the presence or absence of fibrosis by late gadolinium enhancement, but it may be adding other parameters that we look at, such as maybe some of these newer T1 mapping and ECV measures. But that's an area that I think is still under investigation. And Arvind, do you want to?
Yeah, no, I think that's Balakrishnan. You bring up a very good question about, for a long time, people thought fibrosis is reversible in the myocardium until we started expanding this unloading concept with an LVAD. And then after LVAD, we do a pre and post assessment, all the fibrosis seems to go away. There's still a little controversy based on the center, but the ability to predict using MRI for patients who are going for a VAD becomes limited because most of these guys end up having an ICD and they don't all don't have a systematic MRI. So we've tried to look at it, but failed because of the fact that the numbers will be low. I think what Dipan's saying is, from my field of research is recovery. We have a mouse model of recovery where we're studying genetic mechanisms. But using that cohort in humans in medical management, we know about 33% actually recover with medicine. We don't know why those 33 people out of 100 recover and others don't. So I think there is a future where we'll be able to not just put a VAD to unload, but then enhance with some therapeutics which are specific to promote recovery. In the restage study that we're talking about, where we put in a VAD and used a high dose of medical therapy, that data is not published yet, but almost 40% of the VAD patients picked appropriately and could tolerate high dose medicines. They were able to explant the VAD. It's a 3-center study that was presented at IFSOT. So there's a lot more to come. I think that area of recovery with ability to unload and with techniques like MRI with interstitial fibrosis prediction, I think is a future to look forward for.
Thank you. Mona, any comments on Dr. Shah's talk or anything, questions?
Yeah, absolutely brilliant talks, both Dr. Arvind and Dr. Shah. I have to congratulate both of you, brilliant. So I just want to check out that are you all really getting into diastolic dysfunction and 4D intracardiac MR with flow dynamics and also DTI? Are you all getting into those purviews and what's coming out of there?
Yeah. So that's a great question. So I think there's almost 3 questions there. One is 4D flow imaging. And we have done some work with 4D flow. It's not to the point where we use that as a clinical tool. We do a lot of valvular heart disease cases right now using the predominant, bread and butter techniques of cine and 2D phase contrast. But we are doing, beginning to do some work in 4D flow. The advantages potentially there is not just trying to directly quantify valvular lesions, but actually look at the pattern of the flow, both in the LV, but also in the RV. And there's certainly interesting findings, but again, that's more in the investigational arena right now. The other area I think you talked about was DTI or diffusion tensor imaging, which is really a fairly new concept in CMR. Although it's not a new concept in MRI because it's been done for the brain for many years. We're actually trying to look at the fiber orientation of the myocardium. And so that's an area we have not gotten involved in yet. But again, that's more from a research investigation standpoint. I think that also can provide some very interesting insights. But I think that there's still a lot more work to be done to take that technique from something that's in the research arena is something that can be done in a routine clinical setting, because right now it requires fairly extensive post-processing and optimization to be done.
Totally, yeah. And for diastolic dysfunction, where do you see the echo versus MR?
Right, no, that's a great question. And where we're at Houston Methodist, obviously, we have one of the world's leader in diastology, Sharif Naga, who kind of developed a lot of the initial things. So we as a bread and butter technique, echo is still the first line. There are, we wrote actually a very nice review article for JACC Imaging earlier this year, which kind of highlights the role of CMR for diastolic assessment. And I think probably the strength of CMR is beyond the diastolic physiology. It's actually the diastolic anatomy, in the sense that the anatomic structure abnormalities that you see, not just based on wall thickness, but also based on the ability to look at the tissue composition with the ECV mapping, that I think really probably what we'll see in the future is that the strength of MRI is going to be much more so on the structure abnormality. And then I think echo, because of the temporal resolution issues, is still very robust when it comes to diastolic physiology, for lack of a better word. So I think, again, that's an area where, I hate to defer to echo on anything, but that's an area where I think, they've really done a great job. Sharif has over the last 25 years in his career. And the temporal resolution that you get with spectral Doppler MRI today just can't match that.
True. Thank you.
Let me just pose this question to both of you. Actually, this is something which has been asked by multiple people. In terms of when it comes to sarcoid, what is your imaging algorithm? I know you would do the basic EKG, you would do your echocardiography. Would you do both cardiac MR for your patients and PET, or would you go for one before the other? And how does that decision get taken? Arvind, if you start off, please.
Yeah, I think it makes relevance. But just a comment on the diastolic dysfunction, don't forget cath lab. I know but we're beginning to use a lot more. I think right heart with exercise is very underdiagnosed. And in the research clinical field, we're doing pressure volume loop assessments for better characterization. But I think the MRI fibrotic assessment probably adds value to the physiology. So going back to the question of MRI and PET, so our algorithm has been, we start with the CMR, and if the CMR is stone cold normal, then there's really no point of trying to order a PET scan. But, and I think Dipan might have alluded, I'm lucky that we have Dipan around. I've learned MRI to some extent, but the misconception initially that at least our group and a lot of non-imaging guys had is having a diagnosis differential of sarcoid is only a differential based on the pattern. And having extracellular expansion is not equal to fibrosis or not equal to positive active inflammation. So that becomes very important to recognize, because if somebody has a sarcoid diagnosis suspicion, you do MRI. MRI is only telling you the expansion. It could be active granuloma or damage from before. And in those situations, for treatment recommendations, we've used PET scan for activity tracking and also decision making for treatment. I have some patients who end up getting a suspicion of sarcoid, do an MRI. They have lung sarcoid. MRI shows gadolinium uptake, but then they don't have any active cardiac features, and we do a PET scan and PET is completely inactive. So I don't pursue treatment at that stage because there's no activity. That's a long-winded answer, but I'll let Dipan kind of comment on it.
Yeah, no, and I completely agree with Arvind's comments. I think that if you look at where imaging is helpful in sarcoid, I think one is obviously if you have somebody who has known extracardiac, you want to find out if there's cardiac involvement or not. What the MRI will tell you is, one, if there's acute, but also it'll tell you if there's chronic sarcoid involvement. So if the MRI comes back completely normal, then I think you can stop there. I think if you do see an abnormality, then obviously from a treatment standpoint, you want to know what's the extent of the damage, because that can help you from the standpoint of, even if this is all quiescent and chronic damage, you start to think more about arrhythmic risk in these patients if there's a large extent of fibrosis burden. And then also I think for activity for treatment, for acute treatment, I think that's where the PET is useful. And so I think I almost think of it as, in the sarcoid patients, MRI is the gatekeeper to say if there's completely no abnormality of the myocardium, I think you can stop. If you see an abnormality of the myocardium, it helps you to identify arrhythmic risk. And then you need to then kind of do the PET to look for active inflammation, which you would then alter the way that you treat these patients. So I absolutely agree with Arvind's comments.
Mona, please go ahead. You're muted.
I find that the diffusion weighted CMR does a fairly good job of checking on activity. So if you have diffusion weighted imaging, and on that you can see there's hyperintensity in the cardiac, the areas where so you can actually differentiate the acute from the chronic based on the diffusion weighted MR. Yes, you can't use it for prognostication and how much the number has gone down, but I just find that that's fairly good for checking out on initial activity. I don't know, what is your experience on this?
Yeah, so I think I agree with you. I think that the only thing is diffusion weighted MR in the myocardium, in the heart, there's not a lot of sites that are doing that, because again, I think that's still much more of an evolving technique. I think it's much more established, I think, for the brain and other applications like that. In addition to that, also T2 weighted imaging or T2 mapping sometimes is also utilized to try to identify acute inflammation versus chronic. So there are some MR parameters that we can utilize, but I think that the PET data, the PET is probably more validated, more established at this point for tracking activity. But I think you're right, there's emerging MR applications as well.
Arvind, this is a question which I think you've already answered, but in the interest of the whole public knowing this, the question which was asked to you by Dr. Gokhale was, is it possible that in sarcoidosis, transplanted heart can be affected with sarcoid?
Yes, it's less likely. Most, at least in our experience, all the post-transplant outcomes, because you're on a bunch of immunosuppressants, sarcoid activity is really not that bad. I probably have seen maybe one case report where they reported a kind of a lower level of immunosuppression and patient having actually a reporting sarcoid inflammation. But most of the times we don't worry about sarcoid post-transplant.
Okay. And Dipan, this is a question which Arvind has partially answered in the Q&A section, but I'll pose it to you. when you're deciding to do a PET CT, which PET CT would you go for? Would you go for the whole body PET CT to look for lymph nodes, or do you go for a sarcoid specific cardiac PET CT in your normal routine protocol?
Yeah, so our PET program, we have kind of a dedicated cardiac PET program, and they will do a specialized protocol specifically for sarcoidosis, where there's a certain specialized preparation that needs to be done as well. And the coverage area that they get is predominantly through the chest. So it allows you to look at least for adenopathy that's present within the chest, as well as kind of the upper abdomen, as well as look for FDG uptake within the myocardium itself.
Okay. One of the questions which has come from Dr. Sunita, talking about what are the clinical and MRI features of COVID myocarditis. Are you guys seeing much of that, and what is your experience on that?
Okay. So yeah, so that's a great question. I purposefully didn't include some slides on COVID because we could get to, go off for a whole hour on that. So I think that one is it's still an area that we need to learn a lot more about. So there's been a few publications in the literature with really very variable amount of abnormalities that you see. The way I look at it is right now, there's certain imaging findings that we have fairly well validated. I think late gadolinium enhancement. So if there's LGE, there's now a wealth of data over 20 years that seems to be associated with worse outcome across the spectrum of patients. In COVID, most of the series seem to suggest anywhere from a 20 to 30% prevalence of LGE abnormalities. So that certainly does raise concern. Now, the challenge obviously is oftentimes, these patients also have other underlying risk factors. And the question is the myocardial damage that we're seeing by CMR, is it due to the COVID infection itself, or is it due to the underlying risk factors, or is it due to some silent injury that they had before? All of that, I think, has not been well teased out. I think there's also been some recent publications just reporting purely on T1 and T2 abnormalities. And I think that we have to be a little bit more cautious with, because I think the amount of data that says the prognostic significance of purely T1 and T2 abnormalities is not that robust, I think. So, and I'll tell you from our experience, because unfortunately Houston also has been a little bit of a COVID hotspot. So we have a fair number of patients here, and we've imaged some of them. And we are finding, it's not a sky-high rate of prevalence, but there is prevalence of LGE in some of these patients with COVID. Now the question always becomes, what is your definition of myocarditis? If you define myocarditis as just simply anything that causes myocardial damage, then I think we could probably, presume that yes, this LGE that we're seeing is associated with myocarditis. But also the amount of damage that we see doesn't seem to be a huge amount. And again, these are small cases, small series. So I think, there's still a lot more work that needs to be done to try to tweeze out one, what's the significance of this, but also I think, is this due to COVID infection itself, or is this simply due to all the comorbidities that these patients have? I mean, we do know troponin data at least suggests in the hospitalized patients where it's checked that troponin elevations can occur in 20 to 30% of patients with COVID infection.
Thanks, Dipan. I'll ask this to Arvind. Arvind, there was a question which says that in suspected cardiac amyloidosis, if the MR features are fairly characteristic of amyloidosis, is a tissue biopsy of a non-cardiac region sufficient for you to take that patient up for higher level treatment, or would you still insist on getting a myocardial biopsy?
So if I understand it right, if you have an extra cardiac diagnosis of amyloid already, and you have characteristic features of echo MRI, I don't think you need a myocardial biopsy again. If there's any doubt, because the implications are fairly large, then we have done biopsies in a few patients where the LV is not that thick. And to be honest, the more we have access to MRI, the more varied patterns we're seeing. We've had patients, typically MRI, you expect gadolinium uptake all over. We've had patients who have just an endocardial ring, only the inside. And what do? Do you presume it's all amyloid or not. So there's a suspicion, we do it, but if it's clear, especially for transplant, you're quite, the imaging is quite classic by the time you reach that clinical stage. You don't need a biopsy.
Perfect. I think that's very great. We've managed to answer all the questions. Thank you very much, Dipan, and thank you very much, Dr. Arvind, for being here and sharing your knowledge with us. These are very important topics, and the importance of imaging is being highlighted in a lot of places, and these infiltrative cardiomyopathies are always a diagnostic challenge for everybody. So thank you very much. I'll bring in Dr. Karthik to say any final parting words, please.
I think we had an excellent discussion on infiltrated cardiomyopathies. I agree with Vimal. It was a wonderful discussion. I think we have all the questions, and we have become a bit wiser today and making this event a wonderful, memorable one. Thanks a lot.
Thank you so much.
Thank you very much, guys. Have a good morning to all of you,
All right.
and good night to
Okay.
everybody else.
Thank you.
Okay.
Thank
Good
you,
night.
everyone.
Bye-bye.
Good night.